assistant professor in our group, and homegrown because she did her fellowship here. And she's going to talk about some projects from fellowship, but we appreciate her really tackling the QI piece of work for our group. And she is a member of HiCore, and interested in outcomes. And hopefully getting on board soon is Dr. Ott, who is a world-renowned expert in bone health, and frequent NPR commentator as well. And really just a delightful person who's helped us really try to put together what's logical for the long-term management of breast cancer. And I think what's different about our patients is that they live a long time. And so we have to really think about the whole longitudinal use of the bisphosphonates and other bone healing drugs. And we're really different than the myeloma picture, which is the other indication where it's really part of the therapy for the disease. This is really more about bone density and bone healing from metastatic disease, but I don't know that it's a direct therapy. So there's a little bit of a controversial topic that Dr. Manhauer has agreed to take on. But yeah, in the absence of Dr. Ott, probably best to get started.
All right, thank you, Hannah, for that introduction. I'm just going to go ahead and share my screen. And does everyone, let's see my screen here?
Yep. Beautiful background, but you want to go into present mode. Yeah, there you go.
All right, that sounds good to all right, wonderful. So thank you again, Hannah, for letting me speak on this very important topic. So I wanted to take the time today to talk a little bit about the bone modifying agent use in breast cancer, in particular our group, and hopefully come up with unifying practice patterns. And I'm hoping Dr. Ott will be able to join us because, again, like Hannah emphasized, she is really a world-renowned expert on this topic. And so just a brief outline of some of the topics I'd like to discuss today. First, I want to talk about our utilization and the indications for utilization across a spectrum of indications, including the adjuvant breast cancer setting, as well as metastatic, and also looking at the treatment of bone loss due to breast cancer therapies. And I wanted to share a QI project that I performed with Dr. Keith Eaton that looked at our prescribing patterns in the metastatic breast cancer setting. And finally, I'll also talk a little bit about a few special populations of interest, including premenopausal women and patients who have osteoporosis. And that kind of segues into coming up with some pathways that we can use as a group to have a unified practice pattern. So why does bone health matter? As Hannah alluded to, we have millions of breast cancer survivors in the US alone, and metastatic breast cancer patients are living longer. And so ultimately the survivorship of these patients, long-term bone health issues, including osteoporosis, are a public health concern. And surprisingly to me, osteoporosis is a very common complication in women. 1 in 2 women actually experience an osteoporotic fracture. And unfortunately, hip fractures are notoriously bad with mortality and morbidity, specifically with patients losing their independence. And I think this is really the goal of our talk, is to prevent this outcome for our patients. One way to prevent and treat bone loss is the use of bone modifying agents. And so the 2 main classes, of course, being bisphosphonates and denosumab. They have slightly different mechanisms of action, but they both reduce bone resorption and bone formation. I think it's important to know that there is a very striking difference in their cost. Zoledronic acid is about $60 a dose compared to denosumab at almost 140-fold increase at almost $2,000 a dose. They both actually carry significant risks that we should be aware of, including hypocalcemia, atypical fractures, which do increase in incidence with duration of use, as well as osteonecrosis of the jaw, although infrequent, is a very serious morbidity for our patients. And here's a nice picture of the osteonecrosis, as well as an atypical bone fracture. I think one difference to consider when choosing these medications is that the benefit of bisphosphonates actually continues beyond treatment discontinuation. Whereas, with the denosumab, after you stop the dose or, miss a dose, there's actually a very significant and serious complication of increased vertebral fracture risk. And I think that's really emphasized here in this picture of a before and after skipping a dose of denosumab. And you can kind of see here and appreciate the loss of height as well as the that's resulting from these vertebral compression fractures. I'll just speak briefly about some other bone modifying agents that you might see used, mainly just to describe their perspective with regards to risk of cancer and breast cancer. So the paratides should not be used, especially because of their risk of cancer in our patients. And, raloxifene can be used for primary prevention of breast cancer in patients with high risk of developing breast cancer, but it's not used in the adjuvant settings typically. It also has similar effects to tamoxifen, but without the uterine side effects. Calcitonin can be safe and it can decrease vertebral fracture risk. Strontium isn't approved or recommended. It has an increased risk of MIs. Thiazides can also, notoriously help to reduce some fracture risk. And romosozumab, which is a monoclonal antibody, is kind of a new kid on the block, and I don't think there's much to say about it with breast cancer yet. So in terms of, adjuvant breast cancer and the use of bone modifying agents, the NCCN recommends consideration of zoledronic acid for postmenopausal women, natural or induced, while they're receiving their adjuvant endocrine therapy. And this recommendation is really based on several large studies that have looked at thousands of women. The EBCTG trial was a meta-analysis of over 26 trials looking at adjuvant bisphosphonates, and they found that in postmenopausal women specifically, there was a benefit and a reduction in bone recurrence specifically through breast cancer, though the breast cancer mortality was not different. And so I think in general, overall, the meta-analysis has suggested that the benefit really is on the order of 2 to 3%. So not a significant benefit, but something to talk about in perhaps our high-risk patients. And there's currently no role for denosumab to be used as an adjuvant treatment for breast cancer. There has been a couple of trials that have looked at this, specifically the ABCSG18 and the DCARE trial that looked at this question of denosumab. And currently, even though there's preclinical evidence suggests that rank ligand inhibition might delay bone metastasis, we have not seen this yet in our outcomes. And so really the only medication that we would consider is zoledronic acid. So the question is, who do we treat? Again, the benefit in the meta-analysis was only seen in the postmenopausal women. And I would actually also bring up that it should be reserved really for patients with high risk for recurrence. 83% of the patients in the EBCTG meta-analysis actually underwent adjuvant chemotherapy. So again, indicating a higher risk population. And I think that, in our patients who already have osteopenia with a high risk of recurrence on a DEXA scan, I think this can be another population that we can consider treating as an adjuvant. The PREDICT, the NHS has a tool, an online tool called PREDICT Breast Cancer, and it's actually a nice tool to, again, emphasize that the adjuvant BMA is not for everyone. So I just kind of plugged in what our typical low risk postmenopausal stage 1 patient might look like. And again, here you can specifically see what the added benefit of bisphosphonates are, and you can see that there's really no added benefit in stage 1 low risk patients. And so the addition of bisphosphonates, can be considered in high risk patients, but it absolutely does not replace the benefit of endocrine or chemotherapy if needed. So then finally, what agent do we use? The majority of data has been for zoledronic acid. SWOG 0307 did also look at the oral cladronate option, and this is an option in European countries, but not approved in the US. In terms of dosing and duration, most consensus panel recommend 4 milligrams of zoledronic acid every 6 months for about 3 to 5 years. And that's kind of been, I think, the general practice pattern in our group as well. But I would bring our attention to some newer data and emerging data that suggests that perhaps a different dosing and duration might be appropriate for our patients. And this was actually results of the SUCCESS-A trial that was published in the JAMA Oncology just earlier this year. And this was a phase 3 randomized controlled trial looking at high-risk patients specifically, who really should be the ones that are receiving adjuvant bone modifying agents. And all these patients underwent chemo and were either node positive or node negative with high risk clinical features. And they were randomized to either 2 or 5 years of adjuvant zoledronic acid. And first, for 2 years, they got it every 3 months. And for the 5-year population cohort, they received Q3 month dosing for the first 2 years, just like the intervention arm, and then the subsequent 3 years were Q6 month dosing. So it's important to note that the dosing schedule is different and intensified compared to what we are typically using right now in the adjuvant setting. Their primary outcome was disease-free survival. And as you can see here in the Kaplan-Meier curves, there's really no difference in disease-free survival or overall survival. They did note that there were higher adverse event rates, particularly for skeletal related events and bone pain and arthralgias with the 5 years of treatment. I think ultimately this suggests that the current recommendation for bisphosphonate therapy for 3 to 5 years could be reduced to 2 years with an intensified regimen. And then, switching gears to looking at, treating breast cancer associated bone loss, we, always want to think about the culprits that are, increasing our patients at risk for bone loss. Aromatase inhibitors, classically in our postmenopausal women, tamoxifen, actually only in premenopausal women, and postmenopausal women, tamoxifen can actually protect against bone density loss, and ovarian suppression, and then chemo that of course results in premature ovarian dysfunction, as well as steroids. There are, variable effects on by the different meds on the bone density. For example, women treated with an AI could really experience a 2 to 4-fold increase in the rate of bone loss compared to the expected physiological rate. And within 5 years of AI therapy, there's a 47% increase in odds ratio for bone fracture. And women undergoing cancer-induced menopause, whether it's ovarian function suppression or ablation or removal of ovaries, there's actually a substantial loss of BM bone mineral density acutely, typically really within the first 2 years. But whether the cumulative loss of bone mineral density in these patients is different from what occurs during natural menopause over a period of years is not quite known. So then, when do we start treating these patients for, breast cancer associated bone loss? And the recommendation is really the same as a general population. So if they have a history of what seems like a fragility fracture or evidence of osteoporosis defined by a T-score of less than 2.5 on their DEXA, we would consider treatment. And then also in patients with osteopenia with, T-scores between -1.0 and 2.5, who also have a high risk. And so you can actually determine this by plugging in their information to the FRAX tool, and then it'll give you an output of their 10-year probability of a hip fracture or a combined major osteoporotic fracture. And based on this, even in osteopenic patients, you can consider treating with a bone modifying agent. In terms of what agent to use, both bisphosphonates and denosumab can be used for prevention and treatment. Zoledronic acid 5 milligrams annually has been standardly the dose used, but there's actually new data suggesting that a less frequent dosing is okay. And denosumab 60 milligrams every 6 months is the alternative option to that. In terms of duration and reassessment, I think in general, the osteoporosis guidelines and the FDA really recommend no more than 5 years of continuous treatment with periodic reevaluation with DEXA scan. There's also some biochemical markers of bone turnover that are used, including the urine T telepeptide. And I have seen this used by our endocrinology colleagues and would be interested to see Dr. Ott's thoughts on using this more routinely, even in our breast cancer patients. think one caution whenever we're using these agents is, again, in addition to the risks of hypocalcemia and atypical fractures, there's also caution in patients with renal dysfunction. Zoledronic acid definitely can cause renal toxicity, and perhaps more at risk are patients who have CKD at baseline. And denosumab can result in hypocalcemia that can be even worse in patients with hypocalcemia. And both agents, again, can cause secondary hyperparathyroidism in our patients with malabsorption. So then I want to switch gears to the metastatic setting. And so here, we do consider treatment in patients who have bone dominant disease. And I think you also want to consider the, expected longevity of the patient. It typically takes at least 6 months to obtain the benefit for a skeletal related event reduction. And so really in patients in whom SREs are unlikely, those with minimal tumor burden or those with a limited or short duration of expected survival, treatment with an osteoclast inhibitor should be considered really on a case-to-case basis. And the indications is to reduce the primary and secondary prevention of an SRE. In terms of what agent to use, there's several meta-analyses that have been done that have looked at multiple phase 3 trials that have compared denosumab to zoledronic acid for bone disease, and they actually concluded that denosumab was actually superior to zoledronic acid in reducing the risk of the first SRE and in delaying the time to first SRE. There's also quality of life benefits related to administration, which favors denosumab. However, the overall survival and disease progression rates were similar with both treatments. Based on this, the NCCN and the and the Journal of Clinical Oncology has guidelines for the agents that we use. And, zoledronic acid and denosumab, I think, are primarily the agents that we use for metastatic patients. The dose and the duration have actually been studied most recently for zoledronic acid. 4 milligrams every month was actually pretty standard, but then over in the about 2015, 2016, the Zoom and Optimize 2 were phase 3 studies that showed that zoledronic acid every 3 months was actually non-inferior to the monthly dose. And so this is another option, and I think a very reasonable option for our patients. Less frequent dosing of the denosumab is actually being studied in the REACT BCTA, which is an open randomized trial that's looking at metastatic breast cancer patients, both in prostate and breast cancer, actually did show that the every 3 month version is non-inferior. I think we're still waiting on another study, the reduced trial in it's a Swiss trial that's looking at denosumab every 4 or every 12 weeks before we should routinely consider the less frequent interval. And, I just wanted to share this QI project that I did with Dr. Eaton because it's, related to BMA utilization in our metastatic patients. And this was looking really at our own institutional practices around BMA utilization and costs. It was a retrospective review that we performed at the SCC and UW during the fiscal years 2015 2020. We identified over 1,400 patients who underwent almost 15,000 administrations, and defined Q1 versus Q3 with a 60-day cutoff. We used wholesale acquisition costs and administration costs from CMS data. We also projected total costs spent and projected potential savings from switching to a less frequent administration of zoledronic acid. Here you can see that over 1,000 patients received zoledronic acid over 8,000 unique administrations, and similarly denosumab over 500 patients with 6,300 administrations of denosumab. You can see that proportionately every year we did use more zoledronic acid administrations, around favoring about 60-40 ratio. I think what's interesting here is that zoledronic acid administrations were fairly constant, even though we're going to find shortly that the transition to Q3 month dosing was increasing over that time, so suggesting that more patients are getting zoledronic acid over denosumab during this time period. Here we look at the breakdown in our disease groups, and unsurprisingly, our breast cancer patients make up the majority of administrations, around 36%. Cumulatively, breast, myeloma, prostate, and kidney account for 80% of the administrations. We also want to look at the trends in breast cancer, specifically with the number of patients receiving zoledronic acid versus denosumab over time. Here, the blue line represents zoledronic acid, and the red line represents denosumab administrations. And we see that although we started off in the fiscal year 2015 using more denosumab than zoledronic acid, more of our breast cancer patients are now receiving zoledronic acid. And then, of course, given the evidence and national guideline recommendations for the Q3 month dosing as a preferred option in metastatic breast cancer, we wanted to assess guideline adherence over time at our institution. And here, this figure shows the number of patients receiving Q1 month versus Q3. The green line is Q1 month, the blue line is Q3. The green line is Q3 month, which is increasing over time. And the blue line is Q1 month administration. And here we can appreciate that there's more Q3 month administration over time, with the highest uptake to the Q3 month in October 2017, which does coincide with the ASCO 2017 update. I will note that there was an upward trend even prior to this update, which does correlate with the randomized controlled trials that were done during this period that established the non-inferiority of the two dosing schedules. And so ultimately, we did see the zoledronic acid administration increase and denosumab decrease in our breast cancer patients. And there was a transition to Q3, but the uptake was not complete. I think clinical pathways for bone modifying agents could facilitate the wider adoption of the Q3 month regimens and translate into really significant cost savings as well. And I think we can utilize EPIC as a way to create user-friendly pathways in order sets to make it easier for clinicians to meet quality care metrics. So then, ultimately, we also want to talk about in our metastatic patients, they are living longer now, and sometimes metastatic patients are considered almost a chronic disease. So we do want to have thoughtful discussions about duration of treatment. Currently, ASCO and ESMO, recommend to continue indefinitely in the absence of excess toxicity, as long as it's aligned with the treatment goals. There's also the option of a treatment holiday, and ESMO actually suggests this at the 2-year mark in patients who are perhaps oligometastatic, who appear to be in remission. And again, because data suggests that treatment should be administered for at least 6 months before taking a holiday, because that's the amount of time that it takes to have a demonstrable reduction in the rate of SREs. And currently, there's only limited data to inform the choice of treatment in patients who experience an SRE while on active therapy. But I think switching to a different inhibitor or the same inhibitor are both options that have been at least retrospectively evaluated. Then looking at some special populations are premenopausal women, who typically receive tamoxifen or a combination of an AI with OFS in our higher risk patients. Both agents in our premenopausal women do have a detrimental effect on bone mineral density. With premenopausal women being treated with chemo especially can have a rate of bone mineral density loss that's 3 to 8% within 12 months of initiating therapy. So this is a very important issue to talk about with our premenopausal women. It's interesting because DEXA scans are more validated in the postmenopausal population. So I would definitely be interested to see what Dr. Ott's thoughts are on using DEXA scans primarily as a mode of monitoring. And many bisphosphonates have been used in small trials. And, although bisphosphonates may improve the bone mineral density, it's not really clear if they actually reduce fracture rates in this population. And, ultimately, a lot of our premenopausal women might still be in childbearing age, and it's important to talk to them that these medications can cross the placenta and are at risk for fetal harm. So it's important to advise our premenopausal childbearing women, especially medications like bisphosphonates can persist after discontinuation. Then, in our patients with osteoporosis, there's a couple of different, approaches to them. Some patients are switched to tamoxifen, which can be bone building in our patients with tamoxifen, and other practice patterns include, keeping them on aromatase inhibitor with close monitoring. I think my preference typically is to actually switch to tamoxifen and, start treating with an osteoclast inhibitor. If they're at high risk for recurrence, I typically do use an adjuvant Zometa dosing, the 4 milligrams. Otherwise, standard osteoporosis treatment dosing could be performed. And then finally, in the clinic day to day, what are some other things that we should be, just thinking about? We should be talking to our patients about calcium and vitamin D, calcium primarily obtained from dietary sources. And it's important to also discuss vitamin D and not really overtreat. The goal should be really in the 20 to 50 range. Discuss with patients that weight loss can cause bone loss, especially if it's not done in conjunction with weight-bearing exercise, which is the most beneficial for building bone density. Talking to them about high-risk lifestyle factors such as tobacco and alcohol, and really, assessing in our patients, especially our geriatric patients, the risk of falling, the risk of, polypharmacy and other high-risk medications like steroids and SSRIs and anticonvulsants. Talking to them about their bone health as it is, if they have a risk already of vertebral compression fractures, doing a FRAC score, reviewing their DEXA scans. And then if they have osteoporosis, I think it's important always to check for vitamin D deficiency for secondary causes, as well as hyperparathyroidism, hyperthyroidism. And then, always before starting a BMA, checking these levels, but also assessing their dental health and making sure that they're not already at risk for osteonecrosis or inflammation of the jaw. And then finally, I just had some proposed pathways for us to consider. I think for our premenopausal women who we are considering treating, when they're on adjuvant endocrine therapy with tamoxifen or AIOFS, getting the baseline DEXA, looking at their bone density, monitoring their bone density, even if it's normal, suggesting measures to improve bone density if they have osteopenia. And then I think ultimately, if they have osteoporosis or, are high risk with some of the treatment options, I think considering referral to our endocrinology colleagues to discuss the utility of BMAs, especially to also discuss their preferences around child rearing, if they're going to be on a BMA is important. And then in our postmenopausal women who classically are started on AIs, always obtaining a baseline bone density, following it and monitoring it, even if it's normal. I think if they have osteopenia and they're also at high risk for recurrence, I think that would be a very reasonable consideration to discuss adjuvant bisphosphonate therapy here. And, we could also, I think with the emerging data from the SUCCESS-A trial, consider a 2-year option with an intensified regimen, or of course the classic 3-year option with the Q6-month dosing. And then again, if they're osteoporosis, we can consider switching them to tamoxifen and continue treating with a BMA for their bone loss. Again, no more than 5 years, and really having pretty close monitoring. And then if there isn't a contraindication to tamoxifen, talking with our endocrinology colleagues, I think is always an option as well. And then in the metastatic, situation, really choosing wisely the patients that we're starting on the treatment, I think is the first step. And then after you're starting treatment, I think it's always reasonable to consider a treatment holiday, because these medications are not without detriment and indefinite treatment, especially with the higher incidence of atypical fractures and osteonecrosis of the jaw that can happen with increased duration. A treatment holiday should be considered. And I think an important point that I think Dr. Ott will also mention is that when stopping denosumab, because of that risk of a rebound vertebral fracture, giving a dose of denosumab and then to kind of avoid some of these complications is a very reasonable approach. And this is actually a slide from Dr. Ott, is that, I think the key takeaway really is that, for each medication you start, specifically, here a bone modifying agent, we should really have a plan for the duration and the follow-up. And I think that's kind of all I have. And I want to thank Dr. Ott, Dr. Keaton, Keith Eaton, and Graylow, as well as the entire breast team. And I'm hoping, I don't see from the chat if participants, if Dr. Ott is here yet.
I'm here. I came just a few minutes late. I'm sorry.
Oh, no problem. I'm sorry,
Yeah.
Doctor. I decided to start. I figured that we could maybe share
Yeah.
some of your slides.
No, I actually have a different talk tomorrow at 12:30 and I got them mixed up.
Oh, sorry about that. But
So,
thank
but
you.
I've
again
been here for most of
joining
your
us.
talk. So, okay, so you want me to just take it away then?
Yeah, that would be great.
And then
I
we can
think-
answer
and then maybe we can
questions.
Take some, yeah, I was gonna say, does anybody have questions right now, or we can kind of wait until the end? I don't think there's any questions, at least in the chat, that I see.
Okay. Okay, so let me show, I'll share my screen. And I'll make this bigger. Okay, so I'm actually going to be starting out with a brief run through of the physiology of what's going on in bone, and it's focusing on what we would imagine would happen in the bone, and it's based on studies of histology where we do bone biopsies. And I'm starting out with actually a biopsy of myself when I was a nephrology fellow, to show the characters involved. Is the mineralized bone will stain either blue or green. These little cells are the osteocytes, and the osteoid surface stains red. So I've made animations based on this, and we're going to start out with the way that we do bone turnover. And again, we have a capillary here in the bone marrow with pre-osteoclasts in it. We have the mineralized bone with lining cells here, and the very important brains of the bone, which are the osteocytes. And the osteoclasts don't have access to the bone itself. In fact, these lining cells prevent even the interstitial fluid. And what will happen is that with any activity of living, you'll get a crack, and you get micro cracks in the bone all the time. And the osteocytes next to the crack will undergo apoptosis, and they will start to secrete growth factors that had been previously laid down. And these are very important for osteoporosis, but they're going to be very important later on to think about when you get a metastasis. There's the osteoclast. Then, because of these growth factors, the lining cells will change shape, and they will form a little canopy in a special base. The capillaries are now open to this edge of the bone, and the osteoclast can come into this space. The growth factors also are going to affect the stromal cells that are going to eventually turn into osteoblasts. So now they proliferate and make pre-osteoblasts. And the pre-osteoblasts are going to make rank ligand. And that's the little blue squares. And the rank ligand will attract the rank receptor on the osteoclast, and they'll form a mature osteoclast, which is ready to resorb bone. So the osteoclast will resorb the bone. And I would point out that the life cycle of the osteoclast is very dependent on the estrogen level. So if you have estrogen deficiency, the osteoclast has a longer lifespan because estrogen increases apoptosis of the osteoclast. So that's one of the main reasons why women who are estrogen deficient have osteoporosis. So now it undergoes apoptosis. And meanwhile, the osteoblasts make osteoprotegerin to stop the whole process. They block the rank ligand, and so we're going to stop resorption. And now these cells are going to come into the space. Oops. we'll watch this once more. Okay. And they're going to fill up the cavity and fill it in with brand new bone. So the red is the unmineralized bone and the green color is mineral coming in. Some of the osteoclasts remain behind, blasts remain behind, and some of them turn into lining cells and osteocytes. They all reconnect. The osteocytes start making sclerostin, which is the protein that will inhibit everything to keep things stable. And now we're back where we started. Just to mention the timing, it's about 2 weeks to fill in the cavity, about 3 to 6 months. I'm sorry, 2 weeks to make the cavity, 3 to 6 months to fill it back in, and about 3 years for the mineral to completely come back in. Now I'm going to zoom in even a little further at the osteoblast. As it's laying down the bone collagen, it lays it down as a propeptide, and then this gets cleaved into the collagen, and the propeptides are circulating, and we can measure those. So these are important markers of formation. That's the P1NP. Then meanwhile, the P1NP is there measuring the formation. The collagen then is covalently bonded to each other to make it stronger. And these are called collagen crosslinks. They're pyridinoline links. And about 5 years on the average goes by until now that area of bone is going to get resorbed. Here's the osteoclast, the creatine cathepsin, which is going to cleave all of these collagen molecules, and the fragments containing the covalent cross-linking bonds are released, and they will come out into the blood or the urine. And I happen to use the NTX more often. Other places use the CTX. The NTX can be measured in the urine. The CTX can be measured best in the serum. But one of our faculty actually developed the assays for the NTX a long time ago. So we've just had long-term familiarity with using that one. And both of these are measuring the turnover, the resorption of your bone. So now we step back just a little further and look at what happens to one, what we call bone metabolic unit. And I'm just putting it all together here. Oops, sorry. There. So you get the crack. The osteoclasts come in first, then the osteoblasts follow, and then the osteoblasts make osteoid, and then that gets mineralized into bone. Eventually, you're going to fill in a cavity, and you're going to refresh your bone and have a new package of bone, which is stronger than the old bone. You'll note that there's different densities of the bone. This would be old, very mineralized bone. This is brand new bone, which is only moderately mineralized. Just a photograph to again put it all together. Here's what it actually looks like. The osteoclast with the multicellular nuclei, the multinucleated cells, the osteoblasts that are very vigorous at first, and then they get a little narrower as they go down. They're making osteoid now, and down here it's getting mineralized. Okay, so now a couple of animations to show what's happening when you have normal bone. Is we just put that all together, and I'm going to show about 2 or 3 years of what your bone's doing. So your bone is just always active, resorbing, forming, refreshing itself. You get some cracks and you'll heal them up. And somehow we got right into the menopause one. I'm so sorry. Okay, we're going to do this one. Here's the normal one where we're refreshing the bone. Okay. And now we'll go to the one that I mistakenly showed you earlier, with menopause, so you're going to have more resorption. That's the primary problem. And you get perforations in the trabeculae. And this, of course, weakens the bone. Okay, and so you can see this can actually be demonstrated with micro MRIs in just 2 years after a normal menopause, as shown here. So this would be in the tibia, a section of bone, and you can get basically a virtual biopsy, so they can measure that same spot year by year. And this can be shown like right here. Here's the baseline, and you can see a perforation here. You can see right in here that you've lost this element. And so within a couple of years, you're already weakening your bone. Estrogen is just incredibly important, and that's why it's so hard for us to treat the patients who've had breast cancer. When you guys are trying to keep the estrogen as low as possible, and of course that's hard on the bone. So we'll just go through again what the estrogen effects are. It's like, let me tell the ways. Okay, so first of all, there's T cells in the marrow. Estrogens suppress the cytokines that will then go and feed back into osteoclasts. And the important ones are interleukin 6, and TNF, and also rank ligand. So that will reduce the number of osteoclasts. Okay, on the osteoblasts, estrogen will prolong their lifespan, which promotes bone formation, and it increases the production of TGF-beta. Now, the osteoblasts make TGF-beta that they lay down into the bone, and it remains there until later on when it's going to get resorbed. Estrogen has these effects on prolonging the lifespan. On the osteocyte, estrogen will decrease the production of rank ligand. And so that's again going to reduce the number of osteoclasts. And it will decrease the sclerostin, so that it's inhibiting the inhibitor. And if you treat somebody who is estrogen deficient with estrogen, then you're going to increase Wnt signaling. And Wnt signaling is necessary for these pre-osteoblasts to turn into osteoblasts. It's our brand new medicine, is that we can block sclerostin with an antibody and get a really marked anabolic effect. And the fourth way, and probably the most important, is that it shortens the osteoclast lifespan. So if you're deficient, you'll get bone resorption. And just showing that we'll see this with markers. So here's the NTX as you go through menopause. This study happened to divide the women into tertiles according to their body mass index. So the thin women have more bone loss going through menopause as measured by their NTX. And the heavy women are a little better off, but they all lose. And this would be what would happen if you had osteoporosis and you gave estrogen back. So for 6 months, it's normal. Now we give the estrogen or a SERM. And it's just mildly slowing it down. So it's not all that dramatic, but I actually drew these to scale, both according to time and to duration, and what we see on the biopsies. And what you don't see is that there's no more perforations. And so it's modestly making the bone go up, but it's definitely making the perforations less and making the bone stronger. And so if we look at what happens to the markers with either raloxifene or estrogen, and I think the same thing would happen to tamoxifen, you're going to see that one of the markers of bone formation is alkaline phosphatase. It goes down with estrogen and a little bit less so with raloxifene. And the C-terminal resorption goes down. So you're just turning your turnover down, and that actually is going to be helpful. And let's contrast that to what happens with bisphosphonates. So it'll be 6 months of high turnover, and then we give the bisphosphonates, which look like little blue diamonds, and they go to areas of resorption and stop the resorption. Okay. So now you're no longer resorbing. You're hardly forming anything because you're not resorbing. And if you get cracks, you can't heal them. And so they accumulate. And they accumulate the longer you stay on bisphosphonates, the more micro damage you accumulate because you can't resorb it and repair it anymore. And that's responsible for a lot of the clinical consequences we see after very long-term use of these drugs. Also, if you notice that the color is getting darker, that represents mineralization, and you are mineralizing more. And here's just the markers going down. And we're going to, this last one is what happens if we give denosumab. So 6 months without treatment, and now we give a shot, and it just stops resorption and formation altogether. So you're freezing the bone, but you're allowing the mineral to deposit. So it's getting more densely mineralized. Now we stop and we get a rebound. And you very rapidly start perforating your cells. And just showing the markers going extremely low with both the formation and the resorption. So, you know, what we really want to know is what's the long-term effects and what happens if they're discontinued. And I think what happens when you continue these for a long time is you can get atypical fractures, or you can get multiple compression fractures in the case of denosumab, or you can get troubles with the jaw that I think you guys are all familiar with. And I wanted to just end with this cycle, the vicious cycle of bone metastasis. So all of the things that we're talking about apply to osteoporosis, but when you have cancer in the picture, these cancer cells are going to create osteolytic factors that will directly activate the osteoclasts. And so you're going to resorb bone. And if you recall, the osteoblasts had previously laid down TGF-beta, which is a really important growth factor. And the osteoclasts are going to release the TGF-beta, as well as some other ones that are aimed at the osteoblasts. But instead, they're going to come to the cancer cells, and they're going to increase the proliferation of the cancer cells. Then the cancer cells will make more osteolytic factors and cause more bone resorption and more formation. So it's a vicious cycle that leads to the bone metastases. And by giving either zoledronate or denosumab, you're going to stop this cycle because you're going to block the osteoclasts. And that's why those drugs are important. And actually, I'm going to end up with one other slide about, this is a brand new study that is just published about this month. How long does the zoledronate last? This is a study of normal women who were given, well, they had osteopenia, but otherwise pretty normal. They were given one dose of 5 milligrams of zoledronic acid. And the bone density went up, and the other ones were given a placebo randomly. And you could see what happened 10 years later. They still had higher bone density and hadn't come down. Actually, by 10 years, it finally seemed like it was wearing off. And we saw it both in the spine and in the total hip, this very long duration of action. Meanwhile, the dose was really interesting. They also gave 1 and 2.5, and even these lines, even with only 2.5 milligrams of zoledronic acid, you had almost the same increase as you did with 4. It did wear off a little sooner, but still, this is 5 years. And then they gave a second dose and they saw the same thing. So you're getting these increases and changes with very tiny doses, which suggests that we may be really over-treating all of our patients, either the osteoporosis as well as the cancer patients. So that's, and also I mentioned the increased risk. So I think that was all the slides I was planning to show. And I thought maybe we would have some questions.
Thank you so much, Dr. Ott. That was really eye-opening to be able to visualize some of those, the physiology really of what's happening in the bone with those videos. One thing I was myself curious on is the use of, you mentioned you use UTX, the urinary telepeptide, and
Yeah.
what is the best way to use that? Because you know, we can't really be ordering DEXA scans, you know, more frequently than 1 to 2 years, really. So, is this a better way to monitor, and how should we be using it?
So the probably the best way is if you have been using denosumab and you decided that it's time to stop, then you're going to get this terrible rebound. And I think you had shown the picture of the 5 fractures.
Yeah.
So if you give, normally, if you give somebody denosumab, if you give somebody zoledronic acid, their NTX goes really low. It's going to go down to about 20, 15. And it stays that way for, as you could see, well, I guess I didn't show that slide. It stays that way for years. For 10 years, they're still seeing the low levels. However, after denosumab, it goes down a little, but then there tends to be a rebound. So what I do is we will give a dose of zoledronic acid about 8 months after the last injection of denosumab. And then we wait about 3 or 4 months. And the timing of this is it's all kind of new. So we don't really have good advice, but I usually will wait 3 or 4 months and check the I'll do an NTX again, just to see if it's low. And if it's not, you need to do a second dose of the zoledronic. And then you need to, and you still can't just, you can't relax. You have to check again in about another 6 months. Because what denosumab seems to do is to generate these new kind of cells that have been described that are unique and haven't ever been seen before until the denosumab was invented. They're called osteomorphs, and they're fission cells of osteoclasts that can resorb bone rapidly, and they accumulate with the duration of denosumab use. And it seems like somehow they don't get quite eliminated. And so they'll come back, and you're getting these, they're not exactly explained, but they're observed. Even the denosumab, which usually will last, like I showed you, 10 years, seems not to last as long in people who are coming off of denosumab. So the NTX can help you figure out what's going on. As long as the NTX is low, and that slide that I showed of the normal women, we want it to be in the 40s or even maybe a little lower. Then we know that you're not getting that rebound bone loss. And it's easy to get. You just get a urine sample. So patients don't mind getting that. You're going to hear people say, oh, you have to get the second morning void. If you're doing some really careful experiment where you want everything to be as standard and as optimal as possible, that's probably true, because there's a little diurnal variation. But there's diurnal variation in everything we measure. And I don't think clinically it's worth it. I just get the NTX when I see them in the clinic. And if they come in the afternoon, I get it in the afternoon. And then look and see. And, a lot of times it's fine. It comes back 40 and I say, okay, this is great. But if it's coming back 50 or 60 or 120, then you're going to want to. It's also useful, maybe, and there's some studies of people who have mets from cancer who, when you're trying to decide when and where to dose the zoledronic, either one, zoledronate or denosumab, instead of just giving it on this routinely every 3 months, is that even too much?
Mhm.
Or should you wait until you can see that the markers are going up again? And there's been a few small studies that are trying that approach. And it's not completely clear yet, is that going to be safe? But I suspect, as I've seen your studies that you're no longer giving every month, now you're giving every 3 months. You even need to give it every 3 months. That's going to depend a little bit on how aggressive your cancer is, I think. And since that varies from woman to woman, you could have some other, instead of just having one size fits all, you could try to tailor it a little bit and give it more often in the ones with the high NTX. And if the NTX is coming down and staying down, then you could spread it out and not give as much, and perhaps avoid any of the side effects.
That's a really great thought. I think that would be really interesting to be able to use as we learn more about how to use the NTX. But like you said, we're always trying to individualize our care for our patients. So I think that.
Yeah, I think it's an area that could really use some more studies.
Yeah, absolutely.
I try to look it up from time to time, and there's 2 or 3, and they're always kind of small trials that don't really have any definite conclusions, but it's looking like it would work as a way to monitor the patients that you could do very easily.
Yeah.
And, the end, measuring the NTX is a lot less expensive than, giving the medicine. Yeah. Mm-hmm.
Absolutely. I just want to make sure if anybody else on the call want to ask any questions, we've got a world expert here on this, and just wanted to open up the forum.
I think people are feeling very quiet.
Thanks so much for coming, Susan, and really appreciate this. I think the take homes are less is better. Denosumab has a real major drawback that we need to be aware of, but we're managing both osteoporosis, both we're managing cancer, and I think they're just different things, but I think we're given too much. And we're going to try to write some internal protocols, and we'll seek your input on, kind of giving less, because overtreating is a real problem here, and we may be creating harm. And I want to avoid that.
Yeah, I think that's true. There's always this tendency to say, well, cancer is terrible, so we really have to give really lots of strong drugs and let's not worry about the side effects. But after a while, you're going, wait a minute, they are living longer now. And so we do have to worry about these things. And the long-term things didn't, honestly, a 5-year risk doesn't matter too much when your life expectancy is only 1 year. But if it's 6 years, then it's going to matter a lot. So as you guys are getting better at treatment, we have to get better at tailoring it.
Absolutely. Thank you so much again, Dr. Ott, for being here. And if there's not any other questions, I think that we can conclude this talk. But we really appreciate you being here. I loved your videos.
It gives you a sense of what's going on inside that a lot of people, you don't get it from looking at a bone density report.
Yes, absolutely. Yeah, there's so much more going on. It was, great visuals.
Okay. Well, I guess I'll say goodbye.